Alright, this is going to be a quick hand exam. Let's start off with the nerves, and then we'll go by nerves, muscles, tendons. So starting off, the ulnar neurovascular bundle comes in. It's bisected by the FCU tendon. Here's the Flexor Carpi Ulnaris. So the ulnar nerve will come and send a superficial branch. The superficial branch is purely sensory. It goes to the small finger and the ulnar half of the ring finger. Coming with the ulnar nerve, the split happens here, right after Guyon's canal, and the superficial branch goes to these fingers, of course. The deep branch goes through the hypothenaurs. It will innervate all of the hypothenaurs, and then also get the interossei, the ulnar two lumbricals, adductor pollicis, and most importantly, the first dorsal interosseous, which you can have the patient fight against you here, and you can palpate the first dorsal interosseous, which is a great test to determine if there's any nerve compression of the ulnar nerve or ulnar nerve transection, because if they're unable to fire their first dorsal interosseous, then you must suspect that all other proximal muscles innervated by the ulnar nerve are also involved. Alrighty, the musculature, so testing the hypothenars, you can have the patient flex against you. That's just a small finger. You can feel flexor digiti minimi fire. Also, you can have them push against you, abduct, and you can feel abductor digiti minimi. And also you can have them oppose, and you can feel the opponent's digiti minimi fire. So that's the hypothenar compartment. That's all ulnar nerve innervated. To test the interossei, you can quickly test just the first dorsal, or you can have the patient try to fight against you to spread the fingers. That tests all of the interossei. And then also to pinch your finger. Remember, there's dorsal and voral interossei, all ulnar nerve innervated. Alrighty, so we've talked about the ulnar nerve, the sensory branch, the deep motor branch. One quick thing to remember also is that the FDP to the small and the ring finger are all ulnar nerve innervated. So you can have them just flex the tip of their fingers. So just test that. Great. Similarly, if you're going to test the median nerve, just have them flex the long finger and the index finger tips, testing FDP for those. To test FDS, you need to block the FDP for each finger because it's a common muscle belly, and you can see flexing the proximal interphalangeal joint. So that's FDS. Here's the tendon drawn out. You can see there's a decussation. The decussation is drawn a little bit too proximal here, but this is just for hand exam purposes. Camper's chiasm is where the tendons split and FDP runs underneath FDS. So here's the FDP tendon, and then FDS. Again, it's drawn just a little too proximal to be anatomically correct. The other flexor tendons is flexor pollicis longus. Remember, all of them go through the underneath the transverse carpal ligament in the carpal tunnel. This is flexor pollicis longus. It goes through the thenar musculature. You can have them flex the tip of the thumb, so that's FPL. That's innervated by the anterior interosseous nerve. Also, you want to test Flexor Carpi Ulnaris, so have the patient fight against you, and you can palpate FCU there. Similarly, you can have the patient try to radially deviate the wrist, and you can palpate FCR. Right next to FCR, you can palpate the radial artery. Again, the radial artery contributes to the superficial and deep palmar arch, and then also sends a branch deep to the thenar musculature for the Radialis Indices, and then also contributes to the dual blood supply. Remember, the thumb has a volar and a dorsal blood supply. So now we can switch over to the posterior aspect of the hand, or I should say dorsal aspect of the hand. Remember, the posterior cord gives off the radial nerve. The posterior aspect of the hand, or the extensor part, is all going to be posterior cord, aka radial nerve, or posterior interosseous nerve. So this is all posterior interosseous nerve innervated. We can go by compartments. That's the best way to do it. So the first compartment is abductor pollicis longus. It inserts at the base of the thumb metacarpal. Obviously, it abducts the thumb, so you can have them fight, and you can feel that tendon firing. Similarly, extensor pollicis brevis, which is also in the first dorsal compartment, you block EPL like that, and then try to have them extend the thumb, and you can feel that tendon firing because it inserts at the base of the proximal phalanx of the thumb. And to test EPL, you have them lay their hand flat and extend the thumb out of the plane of the table. It's the third dorsal compartment, and it winds around Lister's tubercle. You can see it inserts at the base of the distal phalanx of the thumb. You can nicely feel that tendon and see the course of it. The second compartment is extensor carpi longus and brevis. Again, these are not drawn anatomically perfect just because of the crowding of all the markings, but extensor carpi radialis brevis inserts on the base of the second metacarpal, and ECRB inserts at the base of the third metacarpal. Have the patient extend against you. You can fight and feel these tendons firing. Good. So next up is the extensor indices. Remember, extensor indices and the extensor digiti minimi are both ulnar to the respective extensor digitorum communis tendons that assert on those same fingers. So this is extensor digitorum communis, and then this is extensor indices ulnar to it. Similar here, this is extensor digiti minimi, which is ulnar to extensor digitorum communis to the small finger. What are these little spanning structures here? This is the juncture tendidae. If you do a hook'em horn sign, you can see that the small finger and the index finger can extend individually because of the extensor indices and extensor digiti minimi. Remember, there's no juncture tendidae connecting those. So if you were to try to extend just the ring finger by itself, there's minimal movement because the juncture are holding up the other extensor digitorum communis tendons. The last extensor compartment is extensor carpi ulnaris. You can have the patient fight to extend an ulnar deviation, and you can feel the ECU tendon. This is the extensor retinaculum over zone 7, and that kind of holds all these extensor tendons down into a more mechanically favorable position. Just reviewing quickly some of the extensor tendon anatomy. Remember, you have a central extensor tendon that trifurcates. This sends a central slip that inserts on the base of the middle phalanx, and then these lateral slips that join the lateral bands, which form the conjoined lateral bands that form the terminal extensor tendon at the base of the distal phalanx. So we reviewed radial nerve anatomy. That was motor. One last thing is the superficial radial sensory. It comes out, here's the radial styloid, you feel it. It's about 4 to 5 centimeters proximal where it pierces the fascia, and it'll send branches to the dorsal aspect of the thumb, the dorsal aspect of the index, and then the radial half of the long finger. So that was motor nerve for the radial, sensory for the radial. We flipped over. We got median motor, ulnar sensory, median sensory as well. The last thing is to test, make sure you actually can palpate the pulses of both. And then just to confirm that the hand is well vascularized, have a portable pulse ox, and you can put it on each finger if you're concerned about a vascular injury. And this will give you a more quantitative evaluation of the vascular status of the hand. Also, to get a more quantitative sensory exam, you get a 2-point discriminator. 5 millimeters should be your cutoff, where you have and you test in line with the nerves, and you ask the patient if they feel 2 pokes or if they can only feel 1. You alternate between the 2. If they have a true nerve transection, they should be able to feel nothing. All right, that's a hand exam.